Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Keerthana Pakanati.
Dr. Pagidipati, Misha, welcome to the Heart of Prevention.
Thank you for having me.
Thank you for having me. Excited to be here.
So I'm really excited about this episode because I intend on learning a lot, as this is a new topic for me and many of the people that are listening. And before we get into all of our questions, I'd like to take a moment to talk a little bit about our guests for today's episode. Dr. Neha Pagidipati is an associate professor of medicine and cardiovascular disease prevention specialist at Duke University in the Department of Medicine. She's also the director of the Duke Cardiometabolic Prevention Program. Misha Nazrollahzadeh is the co-founder and CEO of Joyce Health, which is a doctor-prescribed food companion for cardiometabolic patients. Joyce partners with cardiology practices, pairing their patients with registered dietitians and food coaches to make eating well a joyful daily practice. So, we're talking about implementation and prevention today, and everyone talks about what to do when it comes to prevention and what we should be doing, but not exactly how to do it. And so what does real-world implementation mean to each of you? And we'll start with Dr. Pagidipati.
Thank you so much, and thank you, Keerthana, for having me on this amazing program. So it's an excellent question, right? And when I think about implementation, I think about turning what we know into what we actually do, because there is a lot that we know based on all the scientific data, all the clinical trials, all the guidelines that are continually coming out and continually changing. We know a lot about what we should be doing for patients, but unfortunately, what actually happens in real world practice often falls short of what optimal care should look like. So for me, the idea of real world implementation means turning what I know I should be doing based on guidelines and based on data into what it is that I'm actually doing for patients. And so that means being very familiar as a clinician, being very familiar with what the guidelines say, being very familiar with what the data has, but also then understanding how to talk to patients and how to convince patients to make those changes.
Yeah, I'll take this from a little bit of the operator seat. And so our program, so we partner directly with cardiology practices. And so we think about implementation from the moment that a prescription, and I put this in quotes because providers can prescribe our program, from the moment that prescription gets written. And so we have designed everything around how do we make prescribing nutrition very similar to prescribing medication. And so we think about three different pillars. One is, how do we make it really easy for the cardiologist to champion? If they're going to write this prescription, it better be right out of their EHRs, right out of their existing workflows in the office. If they're using MAs to check out patients, that has to be part of how we are, getting this end to end. The second thing we think about is this program going to be financially sustainable for both the patient and the practice? We'll get into this later on, but we thought from the beginning, we thought about, how do we get this reimbursed? How do we make sure that that is a core part of the way the program is set up so that we don't ask patients to pay out of pocket, and that the providers also don't have to say that when they're writing the prescription. And then the last thing we think about is, how do we close the loop? Like, how do we make sure that data flows back to the prescribing clinician via their EHR? How do we make sure that our dietitians are getting the clinician's notes? Like, how do we make sure that data is being exchanged really seamlessly? And those three things together, we really see as our, what the program is built. And so implementation in our minds is following what's already in practice, making it as easy as possible so that it just increases the chance of everything kind of going well.
Yeah, I love that. I think a lot of the time in fellowship, we learn about what we should be doing, and then we get into practice. And depending on what health system we join, we're kind of trying to navigate a lot of unfamiliarity. So I think that makes a lot of sense. And you kind of touched upon this, Misha, but if someone wanted to really start a preventive clinic from an implementation standpoint, I know you talked about your three pillars, but what are really the three things that you think that clinicians should know when they're starting that?
Yeah. And I'm going to take this from a little bit more of a narrow lens of thinking about nutrition care, because I think prevention can mean a lot of things, and there are a lot of different interventions that you can apply here. So let's say you are purely looking to bring nutrition into your practice. I would think about a couple things. First, it's figuring out who is going to be your defined patient archetype, and then what are the clinical nutrition guidelines to support that? Like, what does your program look like? What's the curriculum like? What do you want to kind of like push forward for your patients? And then the second thing, and this is actually probably the most important piece I would say, is that think about both your care team structure and your reimbursement model simultaneously. So are you going to bring in registered dietitians, health coaches, pharmacists, behavioral health experts? And do they all have existing fee for service? Let's, for the sake of this conversation, to make it really simple, right? Going back to ease, fee for service codes that can be billed that make this service eligible for patients, again, reducing the financial burden. Can you kind of can you think across that spectrum of who you're going to bring in, and then what codes they can bill? Is it someone who's already in your practice, or do you have to hire someone? Do you have budget to hire them? How does that actually kind of play out? What do the financials look like? We can go into this a little bit more too as we go along. And then finally, the last thing I would say is, and this goes back again to like closing the loop on a lot of things. I think we talk about closing the loop quite a bit, is do you have a care plan that is, or like some type of care plan artifact, whether it lives in your EHR, whether it lives in some other kind of system of record with your kind of your care team, that is documenting and sharing kind of all of the different touch points that a patient is receiving. And the reason why we talk about the care plan a lot is that as we all know that, and especially within nutrition, right? There's so many times in which patients are making food decisions. There are so many different ways you can intervene asynchronously, which is how we do it oftentimes, to support them. And that is not necessarily being captured and shared back with the entire care team. So we want to have that care plan be something that's consistent and that is kind of up to date. So I would kind of think about what does that artifact look like? How often are you updating it? How do you make sure the right information is showing at the right places for everyone involved? So those are the three things I would say to like kind of get things started from the nutrition lens.
Yeah, and I appreciate that you kind of narrowed it down because you're right, prevention does involve a lot of things, and that can make implementation more difficult as well. Dr. Pagidipati.
Sure. I can take it from the slightly broader lens of starting a kind of a cardio metabolic program or a cardio program, which is something that we've done at Duke. So it's hard to narrow it down to three things. I would say, I'm not going to include this in the three things, but before you start your program, you want to have a very clear vision of what you're trying to accomplish and for whom, because any program can't take care of everyone. And not theoretically, in reality, everybody is a prevention patient. Right? Everybody, whether you've had no events or you've had 5 events, we're still trying to prevent the next one. And so everybody is a prevention patient. So be very clear about what you're trying to accomplish and for which patients before you even get started. So if I had to pick 3 things that are necessary to begin a prevention program, first, you need a very committed and engaged group that is a multidisciplinary team. What multidisciplinary means can mean a lot of things, and a lot of it is going to depend on the resources that you have available to you. Certainly, cardiology, endocrinology, we have nephrology and hepatology. We're very lucky. Not all programs have that, but also, the multidisciplinary care team, which ideally includes nursing and an advanced practice provider and a pharmacy tech and a pharmacist and a dietitian and and a care navigator and a care champion and all of these things. So thinking about what your multidisciplinary care team is going to look like and what you have access to. 2, you need leadership support. You need at your institutional level, you need somebody to say, this is an important thing, because at the end of the day, even if you're not quote unquote asking for a lot of money, and we can talk about that, ideally all of these programs do require funding, but some of us don't have it, like ours had no funding. You still need institutional support. You still need buy-in that that's like the right thing for you to be doing for patient care, even in a fee-for-service system. So institutional support and leadership support. And then 3, I think it is impossible in my own practice to provide care at the level that I want to provide it without somebody helping with prior authorizations. In the prevention space now, we provide some of, if not the most expensive medications in the cardiometabolic area, right? Our meds are expensive, and they're getting more and more expensive. And so it's really hard to provide the care that you want to if you don't have help with prior authorization. So even someone like a pharmacy technician who can help you with prior authorizations is extremely important.
Just going to add maybe one other thing here, which is, as you mentioned, kind of around, it sounds like we'll talk about a little bit like the financial kind of like way of like supporting this as we go along. But I think as we think about setting up like a financially sustainable model, you also need someone in the administrative side and the billing side who's going to know how to get all these things. Probably shows up in prior auth to some degree too, like how to get the MNT codes, the CCM codes, the RPM codes, making sure that they're all able to be built stacked, and kind of make this all sustainable. So I would say like that billing expert also ends up playing a key role in getting everything, the infrastructure set up.
Yeah, I think at the core of it for both of you, no matter what lens we look at it, it's a team sport. And it's really important that you have support from a multitude of disciplines, which kind of gets into my next question. The prevention team, and Dr. Pagidipati, you kind of alluded to this already. Like, what does a prevention team look like? And that can depend on your institution, as you mentioned, but we'll just start off with you.
Sure. I think, as we are increasingly understanding the complex interplay of many different chronic conditions in the context of, the CKM, the cardio kidney metabolic framework, you really need to have a multidisciplinary team. But again, that's not only subspecialists. So if you ask me what an ideal looks like, I don't have that ideal in my clinic, but I can tell you what it would ideally look like. So we do have a bunch of preventive cardiologists. We have endocrinologists, one who's more specialized in diabetes and obesity management, and one who's more specialized in genetic dyslipidemias. We have a nephrologist two nephrologists, one of whom is a resistant hypertension specialist and the other one more broadly in CKN. And we have a hepatologist who specializes in MASLD and MASH. We also have a nurse who somebody needs to ideally provide that kind of coordination navigator role and that was kind of outlined initially in the presidential statement, the CKM presidential statement from a couple of years ago that Chadi and others wrote from the American Heart Association. You need somebody who is going to help decrease the confusion and the fragmentation for the patient, right? When they have many different clinicians and many different people that they're going to and getting medications from, somebody who's going to help them navigate that experience is extremely important. Also having an advanced practice clinician who can fulfill that role, but also see and prescribe according to evidence-based care, a pharmacist and a pharmacy tech. A pharmacist is extremely important, especially in our state. Pharmacists can prescribe, in conjunction with an MD. And so for things like GLP-1s, which require a lot of energy and effort, require a lot of up titration, a lot of side effect monitoring and stuff like that, I think it's incredibly important to have that. We do not have a dietitian. Misha, God, I could use your help.
We need to talk.
We've not been able to figure out the financial model to be able to hire a dietitian just for because there are dietitians within the whole health system that we can refer to, but they're not our dietitian who practices like how we want to practice.
Right.
And who we can kind of interact with on a regular basis. So dietitian would be incredibly important. That's next on my wish list. And then I think health coaching and social work, because so many of our patients who actually have all of these issues and need these medications the most are the patients who can't get access to them. And so understanding not only their medication access needs, but also their broader social determinants of health and being able to begin to address those is incredibly important.
Yeah, I wish we had such an amazing, like we also only have like a sliver of this, in the sense that we I'll come at this a slightly different angle, but I think we always think about for practices or institutions that can't hire an RD or sustain the cost of that on the team, we're almost this like plug and play opportunity where you can have an embedded dietitian without having, because that ends up, we'll talk about this later, but that ends up being a big kind of barrier to folks bringing them in. When we think about the ideal prevention team, we are trying to take that pamphlet. I know the My Plate pamphlets have kind of disappeared, but we still think of it that way. We try to take that pamphlet to life. Like for most of our patients, they're just trying to answer what's for dinner. What's for lunch? What's the snack? What's the dressing I can buy at the grocery store? That's where the things get stuck. And so our team has board certified registered dietitians that are leading all the medical nutrition therapy, but then they're all augmented or kind of enhanced with, we have a team of food coaches, and it's a little bit unique to us. Our food coaches are like foodies. They know every snack brand and every aisle, every dressing, and they are kind of that extension of a lifestyle or health coach, and they're teaching patients a lot about how to expand their palate, skill building in the culinary medicine arena, and giving them like navigation throughout their full day of food decisions. So that's where we kind of like have been invested in having that food coach that can extend the dietitian's oversight and be there in that daily moment with patients. So that's the other kind of like person I would say that we've really kind of highlighted within our model. And then the last one, and maybe we'll tee up maybe a future question, is that not as a person on the care team, but I think we have to think about team members that are open to operating virtually and or operating with the aid of AI, because there is some of the being able to show up in patients every day means that they can log on from their kitchen or their home, and they can, there's kind of the assistance of all these other new technologies, which is really cool in the world of nutrition. So that's the other thing I would add.
Amazing. Thank you both. And I feel like you guys are just segueing into all the questions. This is great. It is 2026 and we meet the patient where they're at. I think continuously we have this discussion that our careers are patient focused. We came to where we are today and we decided to do what we do for the patient, and everything kind of leads back to them. And so, in the world of AI, CGMs, food tracking apps, things like that, it can kind of be overwhelming for patients and really even for people in the healthcare space to figure out what to recommend their patients and what to recommend that they use. And so, what do you guys think is actually something that's moving the needle? And where do you think any of these technologies lie in that ideal prevention team, given that patients maybe don't have access to that team 24/7? And we'll start with Misha.
Um, I think we've really thought about AI as the glue that sits behind the scenes of everything that we are unlocking for patients. We're using LLMs internally for like two things, for memory and for personalization. So our food coaches, they're real people. They're texting with patients, but they no longer have to remember, oh, this patient hates mushrooms, is allergic to kiwi. They are on these medications that are going to contradict with this one. They are working on fiber this week and they've never tried tahini, but also sheep. But like the level of like detail on what you like to eat can get so nuanced, and patients take it very personally if you forget or if you recommend the same thing twice. Like, I told you I don't like cottage cheese. They're like, oh God. So this part of like allowing us to provide a really personalized experience to patients has been pretty impactful. And I think it's been really interesting to see some of the studies come out on like the role of like what happens if AI coaching alone versus human-led coaching. We're doing a blended model, of course, but like how that kind of can have an impact on patients. I would say that, and I can talk. I would say like the world of wearables is also interesting. This one's more where we see a little bit of a range. Some patients, it's super helpful for them to come in with their 2 weeks of CGM data and the RDs to be able to counsel against that. Other patients, it's almost too much, right? Like they are now like in a frenzy because like my blood sugar has spiked and they think that's a problem. They don't understand that that's okay. And so then it ends up the RDs have to counsel them back from that. So we are seeing, I think without the clinical kind of like infrastructure, the wraparound, and we've seen some pros and cons on that side.
Yeah, I appreciate that thought. I'm sure Dr. Pagidipati will kind of fill us in on the clinical side of it, and
Yeah.
and especially.
Well, on the clinical side, there are so many tools that patients potentially have access to, so many trackers, so many apps, so many devices, so many everything that patients potentially have access to. As a clinician, it's impossible to keep up with all of them. That doesn't mean that there isn't one, a few that you know about that have worked for you or that have worked for some of your patients, and that's very kind of person specific and individualized. What I wish we had was better data on what actually works, but of course, so much of this space is unregulated, and unless they're going for an FDA approval, they really don't have to do any trial work. They can just say it works and then assume. Basically, the way that I approach it is that there's no specific thing that I recommend, but on the other hand, I tell patients to do what works for them. So if they find something, many of these things are not harmful, right? You have to be a little careful if it provides you with kind of odd dietary advice or something like that. But many of these things are not harmful. They're just ways to track and understand better ways, especially if they're using kind of evidence-based dietary patterns for advice. And so I tell them to do whatever works for them, because there's so many different ways and so many different kind of programs that people can be a part of. I guess that's the way that I approach it. And so in some ways, I'm kind of separated from it because that's not what I focus on in my clinical practice, because it's just impossible. There's too many options and there's not enough data around any of them.
Yeah, that's a great point. The fact that they're not seeking FDA approval, so they kind of just put them out into the universe, and patients usually talk to someone, something worked for someone may not work for the other patient. So it's really individualized, as most of prevention is that we've talked about.
I think the one thing to like add on that is that what AI is allowed in many ways is like it is the surface area which a patient needs to engage on can be anything now. And that's, I think, what's really interesting. So my background's in digital health. I've built plenty of apps that really focused on this very one-track way of approaching how a patient had to engage. And a lot of times it forced them to log in and remember their login, which was already like, problem number one. I think now, like in our model, patients will text us photos of what they eat, which is super simple, very easy. And then AI can then like analyze what is sitting behind it. So more so to say this, like to your point, I completely agree that it's whatever works for you is what works best. But I think we're now in this dawn of the actual experience can be molded to what's easiest for the patient. And that's been pretty cool from a technology standpoint.
Yeah, absolutely. And I think I'm just thinking of like my patient population, and it really depends on what patients feel comfortable using too. Because for some people, apps, smartphones, accessibility may not be the biggest issue. For some people, it's even just getting the food on the plate too. So I think that's a big thing that I think about in my clinic. And so I kind of wanted to segue a little bit and talk a little bit about a lot of different ways to build a prevention clinic depending on where your focus is and what that model will look like from an implementation standpoint. Obviously, Dr. Pagidipati, you kind of walked us through how you brought in a multidisciplinary team base, but I was wondering if you could walk us through some examples of models that you've seen or that you think would be good from an implementation standpoint.
Yeah, thanks. It's a great question because every health system has different kind of resources and different things that are available that you can potentially leverage. And so it's good to understand that there is no one type of prevention clinic that is successful. It just depends on what works in your setting and for your population. So, the one that we've developed at Duke is kind of a highly subspecialized, multiple, subspecialists involved. They're not all involved in every patient's care, but we're all kind of collaborating and talking to each other about our kind of communal patients. That is a program that is kind of deep and narrow, I would say. You can't take care of every patient that way. We can't see every patient. It's not meant to take care of the entire population. It's meant to be more of kind of like a quote unquote center of excellence of like tough cases, tough situations. That's who can come to our clinic. Then there are kind of the broader models, right? Of like how at a population health level you can deliver preventive care, which would require a lot more, maybe probably AI, but also just a lot more kind of virtual visits and things like that, and may have fewer members of the interdisciplinary care team. There are other models out there. My friend Ian Neelan has developed the Cinema Clinic in Cleveland, and that he is a preventive cardiologist, but they also have diabetes care specialists, and they also have care navigators. And that care navigator, again, is a really critical role. The Cardiometabolic Health Alliance is another program that's now been kind of acquired by the American Heart Association. That also is a model where it's primarily a cardiologist and a diabetes care specialist. So they're mostly focused on patients with diabetes at high risk for atherosclerotic cardiovascular disease or heart failure. And that's another, type of model. So there is no one, I just want to say that there's no one type of model that can work. It also depends on what your goals are. Like, are you trying to take care of the sickest in your population? Or are you trying to take care of everyone? Those are two totally different models of how you're gonna run that program.
Yeah, that's such a great point, and especially, like, in my institution and kind of the general area, we don't have a dedicated prevention program. And there's two schools of thoughts you mentioned. Everyone needs prevention, and so what kind of patient population are you really trying to treat? Just lots of gears moving in my brain, as you were describing. Kind of, there's no one way to do it, and there are a lot of different ways as long as you tailor to what patient population you're really trying to treat. Nisha, do you have any comments?
Um, I think it's been mostly covered. So the only thing that I've always like admired and looked at is institutions with teaching kitchens or with food pantry integrations that like are starting to think about that, how to bring that skill building in. That's always like also an interesting like level. But yeah.
Yeah, that's a great point. I think in a perfect world, like especially in areas where there's food deserts for our patients, having that option would be huge. So I kind of want to pivot a little bit. I talked briefly about, the process of building it, but then we haven't really touched upon the resources, right? And I know, for example, Dr. Pagidipati mentioned, she's interested in bringing on a dietitian and what that looks like. And you mentioned you had no funding when you started the program. And so
Still don't. I still don't have funding.
still don't. Oh, okay. No, so I heard that correctly. boots on the ground progress. I mean, I think that's huge and very inspiring for a lot of us that are training in like smaller, more community-based programs. And so, what are your recommendations to really, for smaller resource limited practices, to really learn how to implement prevention effectively? Like, especially if maybe we don't have the resources that you've described and that you've worked so hard to bring to your institution, but we want to start implementing prevention at a clinic level.
Yeah, it's a great question. And it kind of gets back to what Misha was saying. You do need to build a business case, right? Of like what is minimum that you think you need to provide the care that you need for the patient population. Define who that patient population is very carefully and think about what at the very minimum you need and make that business case for what that return on investment could be. I think, if I were to start over with kind of bare minimum, again, so our clinic is kind of a coalition of the willing. There's just an amazing group of clinicians across a whole bunch of different divisions, and they're coming to us and saying, we want to work with you. But we're all seeing patients within our own divisions, because that's in the academic setting that we work in. The financial stream is within your own division. And so we all are seeing patients within our own division that the fees that we generate, the RVUs, go back within our division. But what we're trying to do is, at least within our group, talk about the patients that we're taking care of, make sure that they're being referred to each of us kind of as is appropriate. If I had to ask for money for only one resource, if I had nothing else, but I could ask for money for one resource, I'm going to say it again. It's somebody to help with prior authorizations, because that is the biggest barrier to providing preventive care, I think, is being able to prescribe the therapies and then get access to them. No less important is dietary advice and so forth, but at the very least, like, at least I can begin. I'm not a dietitian, but at least I can begin to have the conversation. But it's impossible if I can't get any medications for my patients. But that's not to minimize the importance of a dietitian.
No, more than half of our patients are on GLP-1s, and as you know, to kind of dive on that one. So we
Yeah, it's
like
critical.
it's
All are critically important.
yeah.
I was just going to say, I think the point that you made, that kind of drives a lot of the care that we're able to give our patients, is the stuff that we see behind the scenes, right? And especially in training, we're so locked in on like, oh, we're going to order something, and then it just kind of goes into the atmosphere, and then, or we're calling in between and we're trying to kind of navigate that while we're also doing other rotations, but we don't really know how much work goes behind the scenes until we're out in practice.
That's exactly right. As a fellow, you kind of, you can kind of come into clinic and you do your thing, and the orders go back to the the labs go back to the attending, other cells go back to the attending. You don't have to bill for anything, and you don't have to deal with the 50,000 phone calls that come in afterwards saying, you've prescribed something that will make me bankrupt. How can you help me? Help me apply for the patient assistance programs. I don't know how to fill out these forms. Who's going to help me fill out all the forms? Somebody has to do that. And as a clinician, that's an important thing, but we also just don't have the time or even the knowledge to do it very well. And so having somebody who's dedicated to that work is critically important.
No, I think that's definitely going to be a learning curve for a lot of us trainees. So I'm glad that we're talking about it now.
I think so, without implicating any particular place, but we have a partner that we work with that. So in our model, we hire our RDs, and our RDs all work within health systems, and then they do part-time longitudinal care with us. So think of like and we have one partner that they ask to refer patients to us, and we normally don't do a refer model. They refer patients to us because they could not get their patients, and this was an endocrinology obesity medicine department, into their own RDs, and those were RDs that we had hired. So they cut through all their own referral red tape and time to appointment by bringing us in. And it was one of these things where it's like, well, there's, if we back into this, there was also there's a business case to be made around, well, you're leaving money on the table, for thinking up to up at the CFO level administration. So it was just an interesting thing that it's the same person. It's just how the patient could get access to it was easier through this partnership model than it was through their own kind of routing within. And I know that there's a lot of complications that I don't quite understand yet, but in some ways, this is maybe an encouragement to those, if you can find a partner who will work with you to help make a business case, and if you could champion within your system on why this is important, the partner, someone like us, we can build that for why it will be beneficial to the system at whole, both from an outcomes and a financial setup.
Yeah, absolutely. No, I feel like that makes a lot of sense. And that kind of segues into my next question, which was how do you demonstrate value and attempt to get financial support from the institution, whether that's administration, leadership, and, we've talked about kind of all the resources and things we have to find to build the program, but how do we really start by getting the institution on board? I would say.
I can share maybe a small anecdote. And so we primarily today work with private practices just because the time to contract is faster. And the pitch to them is that now you have something to prescribe to your patients around nutrition. But in addition to that, there's also financial upside to the practice. So there is it's a doing well by doing good setup. There is a portion that the practice is able to gain. And so then that model is also one that can be um, it incentivizes everyone to some degree. Again, not that we're in I think private practices are thinking about slightly different, um, the thing about the business behind it as well. But that's one thing that we've done here that helps it help make the case is that there is an upside with very little investment. And that's the other piece. We talked about this in the beginning that you don't have to take on the cost of the RD, but you do get to kind of benefit from some of the upside.
Yeah, I can just add to that. I think in a traditional fee for service model, which most systems in the US still are, prevention loses money. It doesn't make money. So it's, you have to, exactly as you said, you have to make the case that it's critically important, the same way that primary care is critically important. Primary care doesn't make a lot of money, and yet without it, the whole system falls apart. So I think some of the cases that you can make are one, you can bring new patients into the system with a prevention program. Prevention programs are very popular. Half of our patients are coming from self-referrals. They've just found us. We're not even advertising. They've just found us in the region, not even in our city, like in the entire region. So you can bring new patients in and you can try to make that argument. The other thing to really keep in mind is that, for example, within cardiology, let's say preventive cardiology, since this is the ASPC, yes, it's true that we're not doing procedures, but guess where half of those procedures are coming from? They're coming from our clinic because we get a bunch of high-risk patients. And so if you take into account all of the imaging that we order, all of the caths that we order, all of that, we are very much contributing to the overall, financial to the overall revenue of the division. And so making that argument as well, that the more patients we see, we do contribute in that way. The other thing to keep in mind is that more and more health systems are entering into value-based contracts with certain insurers, whether that's CMS or something else. So for example, we do have a Medicare shared savings population, which is value-based care. If we don't take care of those patients, our system loses money. So making sure that you align with whatever value-based contracts you have in place in your system will also be really helpful.
Yeah, thank you both. I really appreciate the kind of different perspectives that we're talking about here, especially because we know that prevention is a team sport. So, in the interest of time, I just kind of wanted to ask kind of a wrap up question. But when you think about the future of prevention implementation, whether that's in the nutrition space, cardiometabolic, CKM, I mean, lots of different approaches, what are you most optimistic about, or what are you hoping to see kind of as we continue to grow along this in this space? And we'll start with Nisha.
I think it's the convergence of everything at this point, from the medication to the patient awareness to technology to administration paying attention, right? There's been so much, we've talked about this, but there's so much administration related across CMS that's trying to invest in payment models to support prevention. I think that combination has been pretty exciting to watch it come together. And so, and I think that the fact that there's a lot of what we see, at least, we are seeing renewed interest from patients that were because of a lot of the medications that have come out too. They might have been a Weight Watchers patient 20 years ago, and then they got discouraged, but they're excited to kind of start again. And so I think that there's just there are a lot of different pieces here, but those are the ones that I think that the convergence to us is what makes it really exciting to be building this time.
I think my thoughts are pretty similar. We are at a time in prevention where, cardiovascular disease, cardiometabolic disease, the single greatest killer, has been for a long time, continues to be. But now we finally have kind of supply to match the demand in terms of what's available, the therapies, the knowledge in terms of lifestyle and dietary, improvements. We finally know what it is we should be doing, and we finally have therapies and interventions that can meet the demand, that can help people live longer, help to bend the curve of cardiovascular disease. And now all that's left is actually bringing those things together, which is what we're talking about today. Really, what's left is that kind of last mile of implementation of how do we actually get patients on the therapies, doing the lifestyle interventions that we know will make them healthier in order to bend the curve. But that's a good problem to have. It's a much worse problem if you still don't have tools in your toolbox. So that's what makes me optimistic.
Of that. And I feel like we just scratched the surface of implementation. I mean, I know I learned a lot and definitely have a lot of ideas to take back to my institution and even just to like the other cardiologists in the practice to talk to them about it. And really excited to learn more from both of you in the future as well. But thank you so much for taking the time to talk to me, and super excited for our listeners to hear this episode.
Thank you so much.
Thank you so much. It's been a lot of fun.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.